We're going to begin talking about the neurologic system and the differences in pediatrics from adults. Okay, so the central nervous system, with embryologic development, at least by the 4th week of gestation, the neural tube has closed. And at the anterior end of the neural tube is the brain, and then the posterior end is the spinal cord. The brain itself grows until the 5th year of life, and then it stops. So we're going to see their little heads get pretty big, and by the time they're 5, their head should be the adult size, or close to it. At least their brain will no longer be growing. The myelin sheaths, as you know, that's a fatty substance that covers the nerves in the central and the peripheral nervous system. It provides insulation. It helps to conduct electrical impulses. Without myelin, the electrical impulses will travel more slowly. The peripheral nerves are not completely myelinated at birth, and that's why you see coordination and the fine motor skills, things like being able to pick up a Cheerio off of the high chair, that improves as they age. The neural system, neonates function basically from the area below the cortex. So it's a subcortical reflex response is how they're basically living for a little while. So spinal cord reflexes like sucking, and then their heart and their lung functions, those are present. But cortical functions, which are memory and coordination, those are only partly developed. Within the axial skeleton, the skull is not fused at birth. And it shouldn't be, because like we said, the brain is going to grow until they're 5 years old. So we shouldn't have a completely fused skull at birth. It's going to cause a lot of problems if it is. So the anterior fontanelle, the posterior fontanelle closes by 2 to 3 months. And the anterior closes between about 16 and 18 months. Make sure you know the difference, which one is which, and which closes first. Before either of the fontanelles close, any changes in the pressure intracranially will affect the fontanelles. Like you'll see bulging fontanelles, the anterior mostly, if they are overhydrated or have excessive intracranial pressure. And you'll see the fontanelle be slightly sunken or very sunken, depending on the depending on the level of dehydration or fluid they might have in that area. We measure head circumference in all admitted children under the age of 2 because it's a really important assessment to find out whether or not their brain is able to grow at the rate that it should be growing. And then on the next slide, we'll talk about the meninges. All right, so the meninges have 3 layers. There's the dura mater, which is the outer layer. It contains 2 layers within itself. It has lots and lots of blood vessels, and it extends down and in, kind of making like a tent, and little partitions between the dura and the periosteum, and that is called the epidural space. The arachnoid is the middle meningeal layer. It does not have blood supply. It's shaped more like a web, which is why it's the arachnoid layer. It looks like a spider's web. It's a very delicate layer, and it just kind of loosely covers the brain between the dura or I'm sorry, it loosely covers the brain, but between the dura and the arachnoid is the subdural space. And we hear about that one a lot because of subdural hematomas. So there's just enough fluid within the subdural space to prevent the dura mater and the arachnoid from sticking together. The pia mater is the innermost layer. It's a really delicate, transparent layer. It adheres to the outer surface of the brain. It does have vascularity, and arteries and veins are feeding it. And the subarachnoid space is between the pia mater and the arachnoid. It's filled with cerebrospinal fluid that's acting like a cushion to reduce the force of trauma on the brain. Within all of this, there's endothelial cells. So they form a semi-permeable blood-brain barrier that allows certain substances to pass through into the brain, and it prevents others from entering. So a little tidbit for you: infants have about 50 milliliters of cerebrospinal fluid, whereas adults have about 150. So these are some of the differences in the pediatric anatomy and physiology. Um, the brain and spinal development. So the brain and spinal cord make up the central nervous system. At birth, the cranial bones are not really well developed or fused together. This puts a baby at an increased risk for fracture in those areas. Their brain is highly vascular, and that leads to an increased risk for hemorrhaging. And the premature infant is at even higher risk because there's more capillaries in the surrounding the ventricular areas. So the brain tissue that lines the outside of the lateral ventricles, there's lots and lots of capillaries in there, and those are really fragile in the premature infant. Well, in anyone, but even more so in a premature infant, and it's going to lead to intracranial bleeding. It's actually a common finding uh, in utero as well as in early neonate life. Little areas of hemorrhage within the brain that just spontaneously occur and spontaneously resolve. The cranium is really soft in a preterm infant, and any external pressure on it is going to change its shape, and that's going to cause increased pressure on areas of the brain and possibly hemorrhage. They do have sutures and fontanelles when they're premature, just making sure you know. These sutures and fontanelles, they help to make the skull more flexible and help to accommodate for brain growth that continues after birth. And the cervical spine itself is super mobile, meaning it is not as rigid as ours is as an adult. So the neonatal or child cervical spine, it's at a much higher risk for injury. And that's why you see so many bad things happen with shaken baby syndrome and non-accidental trauma. We injure their little cervical spine with the shaking. It's also another reason why car seats are faced backwards, and it's so important to not have any extraneous stuff within the car seat when a baby is put into it, because we don't want to have extra stuff that's moving their head or their cervical spine into a position it shouldn't be in. just in case there's an accident. And here's some more differences in the pediatric anatomy and physiology of the neurologic system. The myelinization, and we talked about the myelin sheath that covers and protects the nerves. Myelinization is incomplete at birth. So the speed and accuracy of the nerve impulses, it increases as myelinization increases, which allows children to develop more fine motor movements. So we start with gross motor, which is, I always think of a baby sitting at a high chair that's just now learning how to eat, and it's gross looking. They just kind of grab things. They try to grab things, but it's a very, almost like if you can imagine a caveman trying to figure out how to do something. It's very heavy and uncoordinated, and they're not using their fingers or fingertips as much as they're using the entire palm of their hand. So that's a gross motor movement. And then over time, it turns into fine motor movement where they're able to develop like the pincer grasp and grab little pieces of things with their fingers and place it into their mouth rather than just rubbing their hand all over their face. So that's the way I remember gross going to fine motor movements. We develop motor movements overall in a cephalocaudal direction, which means head, shoulders, knees, and toes, basically. So cephalo is your head, caudal is your tail. So everything gross starts out in the head and develops down to the tail or the feet. And then we start with fine motor movements starting near the head and going down. Head size, whew, those infants and little kids have really large heads. It's very large in proportion to their body size. And infant and child's neck muscles, again, are not well developed. Okay, so when you do a neurologic examination of an infant or a child, it is different from how you would do it in an adult. So a Glasgow Coma scale, although we're checking the same things, eye opening, response to pain, motor movement, all of that, it's gonna look very different as far as the interpretation. If a child is nonverbal, then the motor response is the most important variable. If they are nonverbal, we wouldn't care very much about their speech, right? Because they don't have any. And we would have to delineate between crying that is a neurological response and crying that is just a normal response. And that can be difficult. So this is a link, and I would like you to go to it if you can, that will show you the difference between an infant and a child's Glasgow Coma scale and how we interpret them. So a result less than or equal to 12 is a severe head injury. A result less than or equal to 8 is a child or an infant that requires possible intubation or ventilation. And then a result that is less than or equal to 6, we need to monitor their intracranial pressure.